This one is on achieving good depth and correct access in modified penile inversion vaginoplasty. Okay. Basically, vaginoplasty is carried out in following indications. One is the commonest indication today is gender incongruence in those assigned male at birth. Also, in case of agenesis and congenital conditions, post-extirpation for malignancies, post-traumatic, post-birthing injuries, etc. Nowadays, there has been a significant increase in the number of TGD people, those who experience gender incongruence, and estimates point towards almost 5% of population being gender variant. And there's a 20-fold increase in number of cases who are coming to our gender affirmation clinics, as has been the experience of Amsterdam cohort and ours too. As per American Society of Plastic Surgery, the gas procedures increased by 155% in 1 year. That is from 2016 to 2017, and there has been a yearly rise. Recent studies indicate a high level of patient satisfaction in cases of feminizing genitoplasty, both general satisfaction and sexual satisfaction, a low rate of complications, and a low incidence of regret as per SOCs 8, which were published in September 2020. What are the prerequisites for feminizing genitoplasty? That patient should meet the diagnostic criterion for gender incongruence, and we use DSM-5 for that. Patient should understand the irreversible nature of surgery and has explored fertility options already, because this surgery will lead to permanent loss of current fertility. Should have reached the age of legal majority, that is 18 years in India, demonstrated capacity to give consent, and has undergone 12 months of gender-affirming hormone therapy. But as per 8th SOCs, the period is now reduced to 6 months, and this is an optional criteria. The patient should have lived in desired gender role for 12 months, because this gives the patient a chance to act out with a reversible maneuver the gender role, and be in that gender role and be satisfied for herself that, look, this is what I'm going to do. Then there should be absence of any psychopathology or any such mental issues have been diagnosed and addressed. Letters for gender affirming medical and surgical therapy from 2 mental health professionals, and as per SOCs 8, only 1 is required. A waiver of liability affidavit, and to stop feminizing hormone therapy, smoking, herbal and other supplements such as vitamin E 4 weeks before surgery to reduce the rate of complications. Now, what are the differences between vaginoplasty in natal and trans women? Basically, the trans women have having male pelvis have a smaller interstitial distance of 3.95 centimeters compared to natal women or biologic women who have 5.2 centimeters. So only thin flaps can be used for vaginoplasty. Then, while natal women have roomy pelvis with a greater space in the utrovesical and the rectouterine pouches, in trans women, it's just a septum. So in natal women, such dilatation techniques and Vecchietti and balloon techniques can be applicable. Then natal women do not require reconstruction of the pudendal organs, while trans women do. But fortunately, in trans women, the male structures are available, and most of these are utilized except corpora and testes to provide flaps for reconstruction. Now, modified penile inversion vaginoplasty has been carried out since long time. It was started by Sir Gillies in 57, and then gradually the procedures were modified, adding a posterior scrotal skin, adding a urethral flap, and using sacrospinous ligament fixation, and using an extended scrotal skin graft, etc. Our procedure consists of using a perineoscrotal flap, which is 15 into 5 centimeter in size. This augments the penile skin flap and hence provides around 60% of neovaginal lining. Thus, we get a longer lining to line a dissected vaginal cavity, and depth of 5 to 6 inches can be achieved in modified penile inversion vaginoplasty. So now, since penile skin doesn't form the whole neovaginal lining, it need not be pulled tightly posteriorly, and thus avoiding the risk of later retraction. And this flap also balances the posterior flap also balances the pull of the anterior flap and thus maintaining the correct vector of posterior-superior new vaginal axis. Other modifications that we often use are preserving long length of spermatic cords, use of a urethral flap to line the vestibule, which is secretory, using everting sutures at neometers, harvest of glands on dorsal neurovascular bundle together with Buck's fascia and dorsal tunica albuginea, refinement of glans reduction while forming clitoral glands, better fixation of clitoral pedicle so that it simulates clitoral body, use of the harvested prepuce to form clitoral hood, sacrospinous ligament fixation of neovagina so there is no incidence of prolapse, reconstruction of labia minora, and use of a smaller vaginal mold initially. And we do discharge our patients to home on day 3 to 5. We institute vaginal dilatation on day 7, and urinary catheter is removed day 8 to 10. We recommend vaginal dilatation 3 times a day to 3 months, and after that with reduced frequency or till resumption of regular sexual intercourse. So our series consisted of around 630 primary FG gas procedures up to July 2020. And all the modifications were in place till March 2015. So we did a retrospective review of our patients from March 2015 to July 2020 with a minimum 6 months follow-up. And 183 patients qualified for this, and average age of 29 years and follow-up of 31 months. There were no cases of injury to bladder or rectum, no urethral stenosis, no neovaginal prolapse, and average operating time was 4 hours. 4.37% patients required blood transfusion, including one who had to be brought back to OR on next day because patient continued to bleed, and we found this bleeder was from tunica albuginea part of clitoral pedicle. Hence, it's very important to, before closing, to look at that aspect, the lateral aspects of tunica albuginea pedicle, because sometimes bleeders are present there. There were 6 partial flap losses, 4 of the penile skin flap, and 1 patient with a double flap, partial flap loss. In this patient, despite VAC and later skin grafting, depth at 8 months was very less. It's only 7.5 centimeters. In our series, we were able to attain a depth of 14 centimeters or more in 86.88% patients and 12 centimeters in 9.29%. And 3.82% patients had a low depth of 7.5 to 9 centimeters. There was intravaginal hair growth in 5.46% patients. These had not opted for laser hair removal because it is in our protocol to advise laser hair removal for those who have excess hair in the area of perineoscrotal skin flap. But these patients had severe dysphoria and needed early surgery. Touch-up procedures were required in 7.1% patients. There was good clitoral sensitivity in 100% patients and normal vaginal access in 100%. 75.96% patients had a satisfactory penetrative sexual intercourse, while 21.31% patients did not attempt intercourse. 2.73% patients could not have sex due to poor sexual experience due to inadequate vaginal dimensions. So this is basically how we do the procedure. This is the perineoscrotal flap here, 15 into 5 centimeter. And here you can see the new clitoris has been formed, and long lengths of cords, as you can see, are preserved. And here you can see the penis has been disassembled into its various components. These consist of the penile skin flap, and here is the new clitoris, the glands are pedicled on the neurovascular bundle. Here is the corpora, here is the urethra, and here is the perineoscrotal skin flap. And you can see the separation here, plain, between the corpus spongiosum and the corpora cavernosa. And you can see here the corpora cavernosa have been cut short, yeah, and the corporal stump has been sutured, and here the glans has been trimmed to form the new clitoris. And here you can see the new clitoris has been formed, and the pedicle has been sutured in a manner that it resembles clitoral body. And urethra is still to be shortened. And here you can see the 4 into 3.5 centimeter urethral flap lining the vestibule. And this is the dissection of vaginal cavity. You can see here are the prostatic lobes, and here's the rectum, and this is the correct plane of dissection. This has been achieved, and here you can see sacrospinous ligament fixation on the right side. And as you can see in this slide, that very long with new vaginal lining, in this case more than 6 inches, has been easily obtained. And these are the set of dilators we use. And these are some immediate post-operative results in our patients, as you can see. And we do an immediate post-op vaginal calibration with the help of dilators. You can see. This dilator is easily able to negotiate the cavity. And we institute vaginal dilatation at around 1 week. Nowadays, we use smaller size dilator. As you could see that this dilator at 1 week would cause some trauma. And these are some late post-operative results in our patients. Now, a word about penile inversion vaginoplasty being carried out by people on insufficiently trained. Now, what this is causes is a wrong posterior axis of the vagina. And sometimes we find there is absence of pudendal organs. Then we have to convert it to peritoneal or sigmoid. Here's one case in point. You can see the wrong axis of the vagina. It's basically anteroposterior, or if you look from above, supro-inferior axis, and you can see the entire pouch is subcutaneous in location. And we had to convert it to sigmoid to correct it. Another patient with the wrong direction, and you can see we had to use peritoneal vaginoplasty, and his extracorporeal TBing of the peritoneum, and we had to correct this. This is the final result. Another very interesting patient of modified penile inversion vaginoplasty had been carried out elsewhere. The patient had absent clitoris, superficial subcutaneous retracted and shallow vaginal lining. The urethral meatus was too anterior. Urethra had not been shortened sufficiently, with the result that when patient sat while passing urine, the urinary stream direction was superior. And patient had a pinpoint meatus or stenosis. The corporal stumps were too long, projecting into the vaginal cavity during arousal of the patient. Besides, these patients also wanted a depth of 8 to 10 inches. So all the issues were addressed and conversion to sigmoid was done. So this is how we found the patient. And as you can see, the extra long corporal stumps have been dissected, and here's the extra long urethra has been dissected. The corporal stumps have been trimmed, and a new urethral meatus has been made, and this is the sigmoid vagina. And in this patient, we had to get a special dilator of around 10 inches long. And you can see that she is using this 10 inches long dilator. So what are the advantages of penile perineoscrotal flap vaginoplasty? That penile inversion vaginoplasty has remained the dominant procedure today because it avoids the need for abdominal surgery with the risk of complications. It overcomes the disadvantage of small penile size, especially those who have been on feminizing hormones since long or who are on puberty blockers. And even in as one can understand, even in a penile size of 5 to 6 inches normally, around 2 inches get consumed when you pull the flap down posteriorly. And then when it gets inside, you get lining of maximum 4 inches if you use only the penile skin. And this is a hard posterior pull. So this limits the vaginal depth, and forces of contraction will later cause this tube to retract back, changing the axis of the vagina. So all these issues are adequately addressed by penile perineoscrotal flap vaginoplasty. Thank you for the patient listening.
Thank you, sir, for a fantastic presentation, sir. You have actually made it very lucid. The way you have explained and all the pictures that you have shown was also very nice, that we were able to understand in great depth how you are able to manage to get such wonderful depths for your patients. I had a couple of questions for you, sir. This is regarding our consents, that this one, because I think should we continue to follow the system where we get consent? I mean, we wait for 12 months after the psychiatric consultation, and also we get 2 psychiatric professionals independent consultation. Or should we avoid that now and we can go for 6 months and single psychiatrist, or should we still continue with what we were following previously?
Well, personally, as per SOCs 8, yes, you can do that, because now only 6 months is required of hormone therapy, and only one MHP consult is required.
Okay.
But yes,
is it
that's what I'm coming to.
Okay.
So what right now, what I would advise is to err on the side of caution, and get a second opinion just to be sure. We do the same thing in our patients who come from abroad, that they usually carry one MHP opinion, and we do take one local opinion as well in them, just to be really very sure that there is no incidence of regret later on. So as far as hormone therapy is concerned, yes, it's an optional criteria. You can, if the SOCs 8 recommend, I think you can go for that 6 months period. But I would still advise going for around 12 months of real life, so-called real life experience, because it enables patients to wear dresses in all seasons, all occasions, visit the offices, visit the school, college, and visit a lot of places dressed in the desired gender role, and to experience firsthand with a reversible maneuver the implications of being in that gender role. So I would advise this, yeah, that should continue.
So regarding the cases that you have actually operated, where a revision surgery, where actually people come with wrong direction of the vagina and inadequate length, etc. You also mentioned about cases where that clitoris was not there. So, is it possible for us to help these kind of patients who have already lost all their the potential glands tissue and the potential for getting a clitoris and good sensation? Is there something that can be done for these kind of patients, sir?
I'm afraid that very little can be done in for that location, that particular location, because that clitoris is lost irreversibly. It glands at the neurovascular bundle. But I do find a spot where we would locate the clitoris. I do find a sensate spot there, though it's not as sensate as the clitoris we make. So there is a little bit of sensation patient has there. So one is that thing, and another erogenous, highly erogenous area in trans women is the prostate. So if you direct your finger inside the vaginal canal and the normal location of prostate, and if you gently massage it, it's highly erogenous, almost as erogenous as the clitoris itself. So I ask my patients to indulge in sort of foreplay and stimulate that area before having sex. So that area gets stimulated, and they do experience orgasm with stimulation of that area.
Okay, sir. Sir, what about your experience with peritoneal flaps? So you had actually used peritoneal flaps in some of your redo cases, no, sir?
Yes. Now, we actually use peritoneal flap pedicled on deep inferior epigastric vessels, while some people do a sliding peritoneal flap, and some use it on a broad base uh, based on the bladder uh, peritoneum with a broad base. I still feel that it's an emerging technique. And even if you take peritoneum from much above the umbilicus, once you bring it down, I don't think it may be possible to achieve a depth of more than 6 to 7 inches with the peritoneum. So in this scenario, you have to carefully select the patient and certainly try and not to offer it as a salvage procedure, because if that goes wrong, then patient has two failed surgeries, one penile inversion and then a peritoneal. I would, in 90% of the cases, I would prefer sigmoid as a salvage surgery rather than peritoneal.
Sir, another intriguing question was, like our the scrotal flap that you take is 5 inch 15 centimeters, and the penile skin as like part of the penile skin we have to use it for the introitus area, and only part of it is being used in the vaginal creation. In
Yes.
spite of that, I see that all your patients have got excellent depth of yours, because I could see them, they were using the dilators of more than 15 centimeters, and the whole length they are able to do it. So how is that? What do you do exactly getting additional length? Because I think 60%, only 40% of your, I mean, I think the 60% is from the scrotal flap, so the length of the
It's
vagina.
it's not actually a scrotal flap, it's a perineoscrotal flap.
Then
So
your scrotal flap, yeah.
so yeah, it starts from 1 inches the anal canal, and then it goes towards the scrotum. So it's a part of the perineal flap which is skin which lies uh, superficial to perineal body as well. So a lot of it is perineal skin, and some part of it is scrotal skin. So it's a huge flap, and it's got a lot of elasticity as well, because scrotal skin is highly elastic. So
Okay.
what we do is we are able to dissect the cavity, a long cavity, and the 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 peritoneal reflection in that area is just 7.5 to 8 centimeter from the skin surface. Once you cross the upper limit of prostate, then the dissection becomes easy, and then you can really strip away the peritoneum for a long distance, even more than your finger. You can do with some blunt instrument. You can dissect. So creating a long cavity is not an issue. The thing is fixing that uh, long lining into that area. So so for that you should not take. We use sacrospinal ligament fixation. We do not take it at the tip of this flap. We rather take it on the right side of the flap, a long distance away from the tip. So once we tighten this sacrospinal ligament suture, this flap gets pulled deep into the created cavity. So that's how we are able to achieve good depth.
Thank you, sir. I think it was excellent. So you have mentioned, you've answered all the questions also, sir. Thank you very much, sir.
You're welcome. Should I go on with the second presentation?
Yes, sir. We'll finish it off, sir.
Okay. Sharing. Yeah. So the second presentation is on steps to reduce urinary complication rates during phalloplasty. Now, phalloplasty is the commonest indication today is as part of genital gender affirmation surgery, MG gas, in GI individuals who are assigned female at birth. It is also done in DST, absence of penis, micropenis, individual raised with ambiguous genitalia, raised as male, hypospadias and epispadias with erect penile length of less than 7.5 centimeters, penile loss due to various reasons, etc. And a huge number of patients today have TGD, is approaching almost 5% of general population. And there has been a significant increase in the number of people who are reporting for gender affirmative surgeries. Results from recent studies indicate good satisfaction with sexual function in the range of 77 to 95%, and post-operative satisfaction and ability to void in standing position as per 8th SOCs published in September 2022. However, over the years, the urinary complication rates in phalloplasty have remained high, despite it being performed since almost 1985. So urethral strictures range from 25 to 58% and fistulae from 70 to 75%. So what are the prerequisites for MG gas? It is similar to that of feminizing genitoplasty, as I discussed in my earlier talk. So what are the differences between phalloplasty in natal and transmen? In natal men, only penile urethra requires reconstruction and pars fixa is already there. So in transmen, since pars fixa also requires reconstruction, there are two sharp ends in the urethra. And as a result, it is prone to strictures and fistulae. Also, a greater length needs reconstruction. And second is that penile nerves are larger and easier to dissect than clitoral nerves. So the anastomosis is better in natal men with penile loss. Now, masculinizing genitoplasty is a complex group of operations. It actually consists of 6 to 7 different operations done sometimes at the same time. It includes hysterectomy, salpingo-oophorectomy, vaginectomy, perineal closure, scrotoplasty, pars fixa and pars pendularis reconstruction, then clitoral transposition or mitidoplasty, phalloplasty, and insertion of penile and testicular prosthesis. If all these procedures are done at the same time, then it will be a very major procedure, taxing for the patient, and it will generate a lot of edema in that area, which will increase the risk of complications. As a result, most of the surgeons today carry these out in 2 to 3 sittings. Goals of phalloplasty are that it should provide a rapid, sufficient, and lasting rigidity for sexual intercourse. It should be of aesthetic dimensions. Donor area morbidity should be minimum. Erection should be physiologic state and not permanent. Preferably single stage with good tactile sensation and no urinary issues. Sadly, there's no procedure which is ideal, which can satisfy all the goals. Today, the dominant procedure for phalloplasty remains the forearm flap phalloplasty. You can see here, anterolateral thigh flap has rapidly caught up to be the second most common procedure. And then musculocutaneous latissimus dorsi and other flaps are still being carried out. This is the classical Chang procedure, ulnar forearm urethral strip and a radial forearm body of the penis and 2 dissected nerves and anastomosis with femoral or deep inferior epigastric vessels as per the surgeon's choice. Here is one case in which the flaps have been dissected. This is the penile body flap and this is the urethral flap, and these you can see the neurovascular bundle and penis here still attached to the forearm and transposed to the pubic area, anastomosed. Patient maturating at around 3 weeks, and this is a long-term result. This is a male patient who had a penile loss due to animal attack, and in this case also radial forearm phalloplasty was done. Another patient, and this is immediate post-op penile prosthesis. Another male patient with animal attack, and here are a few of our results. And his patient demonstrating a good urinary stream. I'll show some cases of ALT phalloplasty, and here's a the perineal dissection and the reconstruction of pars fixa urethra. And you can see here the pre-laminated urethra in the flap, and that flap has been transposed and a long-term result. Another patient, the ALT phalloplasty. This is the vaginal mucosal strip, which has been pre-laminated into the thigh. And you can see this is that second stage actually. And this is the final stage. Another patient with well-healed pre-laminated urethra, and this is the long-term result. Another patient with the ALT phalloplasty. And here is a patient with ALT phalloplasty maturity. In this patient, we had used actually an 18-gauge catheter. Nowadays, 24-gauge catheter is what we use. So what are the tips and tricks and refinements to reduce the urinary complications? One is, at the first patient interview itself, ask the patient to preserve the forearm veins. Designate the forearm that this is the forearm with which we are going to do phalloplasty, and then you should spare that forearm, and it should not be used for blood sampling or any other thing. And forearm circumference at lower border of flap should be minimum 15 centimeters. Optimum tissue thickness is 4 to 8 millimeter. If it is less than 4 millimeter, the reconstructed penis tends to be floppy. It bends very easily. And flap should be harvested from lowest possible location near the wrist to capture maximum perforators. Allen's test should confirm patency of arches. Volar aspect of forearm should not be hair bearing, otherwise this will go into the urethra. So ideally laser hair removal should be done. And urethral tube should be planned 3 to 4 centimeters longer than penile shaft tube. Always when one gives a cut for inserting the penis into the pubic area, one should instead of giving a transverse cut, raise a triangular flap. So this can be a lifesaver in certain situations where the closure of the penile tube itself is difficult proximally. And in that case, this flap helps with that area, because if urethra is skin grafted in that area, it will invariably lead to fistula. And we reconstruct pars fixa urethra at the time of hysterectomy and use vaginal mucosal flaps, and grafts are available at that time, so that only one fresh anastomosis, the pars fixa to pendular anastomosis, needs to be done at the time of phalloplasty. Now, this is the lifeboat flap I was talking to you about. We had raised this, and this was a difficult area to close. Closing it was causing vascular compromise, so we left it open and used this lifeboat flap. Then release the natural clitoral chordae and unfold it anteriorly during this second stage itself at the time of hysterectomy. And even with this step and reconstructing a longer urethral tube, often pars fixa, pars pendularis anastomosis is still under undesirable tension. So in the past 5 years, we have been using a technique which we call last mile technique, because it improves the last mile connectivity. So I'll come back to this technique. Then a flap urethra is always better than a mucosal graft urethra, which is always better than a skin graft urethra. So whenever possible, this should be done. For pre-lamination, now we use a 24G suction tube instead of an 18G Foley catheter. And before performing phalloplasty, the pre-laminated area in the flap, the ALT flap, should always be examined with a cystoscope. If there are any granulations, then corrective measures should be taken now rather than later when stricture will be there. So this is what the last mile technique is. This was a conventional technique. Now, pars fixa urethra proximally is formed with the help of anterior vaginal wall flap and inner labia minora flaps. But we were initially not forming the distal pars fixa urethra. We now form that. There's a lot of hairless skin in between the anterior ends of labia majora, together with the dorsal clitoral skin and mons veneris skin. This leads to prolongation of the urethral tube by 4 to 5 centimeters in that area. Now this is crucial because this reduces the tension between this and the pendular urethra. Now this is what is the conventional technique. As you can see, the anterior vaginal wall flap and labia minora flaps right up to the clitoris here. And this is the location of meatus. This is the last mile technique. You can see this is the clitoris here, and conventional technique will form urethra up to here, and this part here will be formed by last mile technique. For this, we give a small incision here, transpose the clitoris to this area, hair bearing skin, pubic area, and then in the plane of clitoral fascia. We take care not to undermine the whole of this flap, and then we give we excise the labia minora like this, and then we make a tube out of this area. So you can see that this part of the tube is extra, and this is the location of the urinary meatus. It's very near the pubic bone. So this shows the difference between the conventional urethral reconstruction, pars fixa, and the last mile, where you can see this is the pubic bone and urethra is right over the pubic bone. And these fibers will be closed. And you can see here, this is the meatus obtained with the conventional technique, and this is the last mile technique. When seen, this view is from the anterior aspect, and this is the clitoris. So this study was published in IJPS in July 2022. In 27 years till 2019, we had performed 431 cases of RAF and 120 cases of ALT. And this was a retrospective review from June 1993 to December 2019. One cohort was till February 2017. It had all the modifications except the last mile technique. And second cohort was with the last mile technique from March 2017 to December 2019. And these are the statistics. So as you can see that 399 of cases and 106 of the ALT cases qualified for the study, including inclusion in the study. And this is what we found, that with conventional technique, the stricture with or without fistula rate was 25.94%, but with last mile technique, it was 4.17%. When using the last mile technique, the urethra, the pars fixa urethra extends by 3 to 4 centimeter, and it practically overlaps the pendular urethra. And this was statistically significant. And as also in the case of ALT, where 43% was the incidence for stricture and 17 was with the last mile technique. This still remains high because the urethra itself is usually a skin grafted urethra. So in this case, stricture can be at other sites as well. And this here is the for the fistulae alone, 12.81% with the conventional technique and 2.78% with the last mile technique. And you can see a p-value. It's a significant result, but just falling short of significance in the case of ALT flap. Thank you so much for the patient listening.
Thank you, sir, for the wonderful presentation, sir. This is one of the most difficult procedures for a trans person in any of the surgeries that we perform for transgender people. One question I wanted to ask you is regarding the initial procedure where we are actually doing using the vaginal mucosa to lengthen the urethra. And could you just explain that? Sir, how it is being done, sir? Because where you take it to the urethra to the edge of the clitoris.
Okay, so no, not that part. We use a conventional triangular flap of anterior vaginal wall, and labia minora to form the proximal part of pars fixa urethra. The distal is formed by the non-hair bearing skin. Only in case of metidoplasty we use vaginal mucosa to line the pendular urethra, the clitoral urethra. But in case of this last mile technique, we don't use vaginal mucosa. We use only the glabra skin.
So the clitoral hood would be there. So that one folds, you retain it, or do you excise it, or what do you do, sir?
During this last mile technique, yes, we.
Yes, a last.
Okay. So once we are transposing the clitoris to the pubic area, we retain a part of clitoral hood, and then this is sutured to that incision there.
Okay.
Yes. So clitoris is basically exactly where it should be when penis will sit on top of it. It is already transposed.
Okay. Okay. And when we are actually going to keep the penis over there, we would actually just denude the clitoral mucosa, and then you will keep the penis, right? Yes, sir.
Yes, just de-epithelize it.
Okay, sir. And what about the metidoplasty, sir? Which is the type of metidoplasty that you prefer to do, sir?
Metidoplasty, we use something similar to what Miro does, Miroslav Djordjevic. So it's what we do is, conventionally, the proximal part is, again, pars fixa is formed the same method. And we use bilateral inner labia minora island flaps. And we slide them backwards. And we use a dorsal clitoral skin flap. We make a small cut in the dorsal clitoral skin and push the clitoris out through that cut. And then this dorsal clitoral skin flap comes on this side, on the ventral side. And on the clitoral surface, we use vaginal mucosal graft. So we form a complete lining. It is usually sufficient for up to a 12 French tube.
Okay. You base it on 12 French or 16 on 12 French only. The urethral diameter, yes. You usually make it 16 French and then decrease it to 12, or it's made at 12 only?
In case of metidoplasty, generally we cannot achieve a closure of more than 12. Okay. Because it's a clitoral surface is smaller.
Okay.
But yes, in phalloplasty we prefer 14 or 16.
Okay, sir. Okay, sir. And what are the donor vessels for your phalloplasty, sir?
Okay, so we use femoral artery and saphenous vein. We take a long loop of saphenous vein and anastomose it to the femoral artery so that there's an arterialized part of saphenous vein and a venous part. And then we are able to easily take that into the pubic area. And during this process, we are able to find at least 2 or 3 additional veins. So we try to do at least a second vein as well.
Okay, sir. Thank you, sir. I think you have answered most of the questions that we have. But of course, it would be a pleasure to actually visit your center and watch you do the phalloplasty, sir. Thank you very much.